Hello and welcome to our very first episode of Powered by Pathology. Let's go. Hello and thank you for joining us. I'm Dr Ben Armstrong and I am a clinical microbiologist and the Director of Microbiology at Douglass Hanly Moir Pathology. Today we are coming to you from Gamma Regal land in Sydney, and I'd like to start by offering my respects to Gamma Regal people and Gamma Regal country, and to all country and nations around Australia wherever you are listening or watching from. Today, we are here to talk to you about digestive and gut health. We are digesting the diagnosis. People might find it difficult or impolite to talk about their guts, but it's an incredibly important system of organs, and it literally fuels and takes care of every other part of our bodies. I'm joined by two incredible Australian experts on gut disease and testing, Professor Michael Wehrhahn and Dr. Caroline Fung. Welcome to you both.
Thank you.
Thank you very much.
Good to be here.
Mike, can you introduce yourself, please, for our listeners?
Glad to. So currently I'm a clinical microbiologist and infectious disease physician. I'm the Director of Molecular Biology and Infectious Serology at Douglass Hanly Moir, and an infectious disease physician to a variety of hospitals where I see patients with complex infections. I'm passionate about education and teaching. So we teach medical registrars, microbiology registrars, and medical students at the University of Notre Dame. And I'm passionate about research, so especially in the area of gut pathogens. And there's one pathogen in particular I'm very fond of that I'm in the middle of a PhD. And that's a gut parasite that's we're still trying to understand its clinical significance, and that's Dientamoeba fragilis, but might touch on that a bit later.
Great. And Caroline, can you please introduce yourself for our listeners?
Sure. I'm an anatomical pathologist. Sometimes we're also known as tissue pathologists or surgical pathologists. And I joined Douglass Hanly Moir end of last year. Prior to that, I have been working in major teaching hospitals for almost 30 years. And my special areas of interest include gastrointestinal tract pathology, renal pathology, as well as in particular, actually, renal transplant pathology. And I've been involved in many collaborative research with the clinician, in particular in liver pathology, inflammatory bowel disease, as well as renal transplant. I am also very interested in teaching and would love to share my knowledge with our juniors, the trainees, as well as medical students.
Welcome to you both.
Thank you.
So people may or may not know, Sonic Pathology Laboratory screen tens of thousands or hundreds of thousands of people each year as part of the National Bowel Cancer Screening Program. And a lot of those people end up having positive tests and then going and having a colonoscopy because of that. And most of those people would have biopsies taken, and then those biopsies would come along to you, Caroline. Can you tell us a little bit about what you look for in a GI biopsy?
Yes. So as I said, my specialty is surgical pathology. And what we do is primarily making diagnosis by examining tissue and cells under the microscope. So this is something a little bit more modern than this, but this is something that I work with every day for 8 to 10 hours at least a day. But in addition to making diagnosis, we also assess other morphological features to provide information regarding prognosis, treatment options, and follow-up recommendations. And in addition to cancer diagnosis, we also examine biopsies for medical diseases. And in the gastrointestinal tract, for example, we would be looking at biopsies showing inflammation of the GI tract, such as gastritis, enteritis, colitis, and in the liver, which is hepatitis. And there are many causes of these conditions. So even for cancer, a lot of people think that cancer is just a generic term. You've got lung cancer, you've got stomach cancer, but there's actually a very complicated classification system. And so we have to actually classify the tumor according to specific WHO classification system, and the treatment for different classes of tumors differ. And so we actually look at not just cancer, but a whole range of medical diseases as well.
And Mike, as an infectious diseases physician and a microbiologist, you also do a lot of work and spend a lot of time identifying and managing people with infectious gut diseases, don't you?
Yes, indeed. So if you think about the last time you had gastroenteritis, if that persisted, often you'll see your doctor and he'll order a stool test, and that'll come to our lab, and we set it up for both culture. That's the more traditional approach, where we try and grow these gut pathogens like Salmonella and Campylobacter, and also look for it by molecular methods. So that gives us a more potentially reliable means. It's a very sensitive test. We've all heard of COVID PCRs perhaps, and we have about 17 different targets that we regularly employ to look for bacterial, parasite and viral pathogens. So with a bit of luck, you'll be able to diagnose that gastroenteritis, but not always. And that's why we've actually got now even more modern methods, metagenomic methods, which allow us to sequence all the DNA in that stool, and without knowing what it might be, we then map those sequence reads to reference genomes that then tell us what those potential pathogens are. And because we're sequencing everything, we get basically a map of the whole microbiome, and we can then determine how healthy that microbiome is by its gut diversity and richness potentially as well. This technology allows us to look for antimicrobial resistance genes as well in the stool sample. So we're really moving towards this sort of era of next-gen sequencing, where hopefully we'll be able to diagnose even more organisms. Just to give you a picture of what we're moving towards, we did a review in our lab about 5 years ago and showed that, for example, there's some rare pathogens like Archibacter that we picked up once in 5 years, and this metagenomic test has picked up 8 in about 1,000. So it's about a 2,000-fold increase in diagnosis of these difficult to isolate pathogens that are not detected on PCR, for example. We've had some amazing discoveries. So perhaps with people, we'd expect maybe between a 5 and 15% positivity rate for these stool samples, especially in those that are having persistent symptoms. But on this new metagenomic test called the MetaPanel, which we partner with Microba in Brisbane, this has allowed us to pick up an additional 20% of pathogens. So it's very exciting, and I could give you some case reports if you'd like in due course, but perhaps we'll leave it at that.
So you're really helping a lot more people with the more advanced methods.
That's right. That's what we're starting to see, yes.
And Caroline, it's probably a misconception, I think, out there that most of the work that you would do would be looking for bowel cancer. But can you tell us a little bit about how you look for other conditions?
Sure. There are a few common misconceptions about our work or the role of a histopathologist. And some people think that we just work behind the scene in isolation in our own offices. And that is very far from the truth. We need to work in close collaboration with our clinical colleagues, and quite often we would collaborate with our pathologist colleagues in different disciplines as well. The reason being that the body tissue or organ generally has a limited range of patterns of injury. So when we receive a sample and we look for abnormal features within the tissue, that would give us a list of differential diagnoses. But to arrive at the final diagnosis, we need to correlate it with clinical things like the blood chemistry, serological findings, and sometimes in the, if we're dealing with cases of infection, then with the microbiological correlation. So for medical diseases, as I previously mentioned, inflammation of the gut is one big area that we receive specimens on very often. And there are many causes. Some of them could be infective, and you could have a whole lot of autoimmune disorders that affect the guts, and they each have their specific morphological features, but not pathognomonic. And that is why we need the correlation with the clinicals. And also some cases, they could be due to medication or drugs, and a drug history in the GI tract is very important, especially in the liver and inflammation of the small bowel, for example. And then there are other toxins and other environmental factors that can predispose to it. So when we get a biopsy, sometimes it's a tumor, but even for tumors, as I mentioned before, we need the exact classification. We need to assess for other features to help the clinician decide on what treatment plan they're going to follow. And then for the non-cancerous cases, there are a whole lot of conditions that affect the GI tract. And so depending on the cause of it, we would need to collaborate with different people to get the final diagnosis. And achieving at the final diagnosis is extremely important because treatment depends on the cause of the problem.
And it's not just about the luminal organs, not just about the bowels. GI pathology includes other organs as well, right? Like the pancreas and
That's
liver?
right. Gastrointestinal tract. I think today mainly we're talking about a few of the conditions, including the luminal, the hollow organs from the mouth to the anus, but definitely liver, the pancreas, the biliary tract, all these are grouped under the gastrointestinal tract, yes, and they each have their specific pathological processes.
Mike, as the director of both serology and molecular biology at DHM, you do a lot of work helping to identify and manage people with viral hepatitis, especially hepatitis C, don't you?
Yes, so this is one area that is very exciting. More recently, there's been some guidelines to recommend reflex testing on patients with evidence of exposure to hepatitis C. So we pick that up by an antibody response. The body comes in contact with these viruses and they produce antibodies, and that's what we detect on serology tests. So there's a recommendation that people who are positive for hepatitis C by serology should then be assessed to see if they're carrying the actual virus, and we do that by molecular methods. So looking by PCR or molecular methods to determine if they are still carrying this virus, because a minority of people will clear this by themselves, but many won't. And so in our lab recently, we published where we adopted this new approach. It was not without its challenges, because we have to make sure that these samples that are positive for the antibodies are not contaminated, for example, and then we can look for the virus in them. And we found over 200 cases actually applying this pathologist-guided reflex testing. And in a significant proportion, these were older people in their more than 60 years old. So it's an important message for listeners that if they are in this age group where they're born between 1945 and 65 roughly, they're at increased risk of carrying this virus chronically and often asymptomatically, or they may just have some mild symptoms like fatigue. And GPs or their regular doctors should always look for that. by serological methods, and then we can then confirm if they're PCR positive. So if they're positive, we now have some amazing treatments. 1 tablet a day for 8 to 12 weeks can cure these chronic viral hepatitis that are caused by hepatitis C. And it brings me back to times 20 years ago when I was a registrar training and seeing these in a weekly hepatitis clinic. These poor patients were getting weekly interferon injections as well as a handful of different medications to take for not just half a year, but a year, and with only the possibility of successfully treating that infection in about 50%, so for the most common genotype 1. So really have moved a long way from that, and pathology can really help diagnose those undiagnosed cases of Hep C and try to prevent that from progressing, because people with chronic viral hepatitis can develop then fibrosis, and that's the fertile soil for hepatocellular carcinoma, as Caroline diagnoses regularly, I'm sure.
And Caroline, once someone is treated for Hep C, now with great rates of success, what is the effect or benefit for the liver?
Chronic hepatitis C can predispose to many complications of the liver. In the old days, the clinicians tend to do a pre-treatment biopsy as a baseline to assess for the degree of inflammation and the amount of scarring, fibrosis. But these days, because of advances in microbiology and also medical imaging, they can do fibroscan to see how much fibrosis there is. They tend not to do that. And so usually, once they start the patient on treatment, occasionally, we will get a biopsy because the liver function test becomes abnormal again. And in that sort of situation, what we're looking for, firstly, is whether there is still persistent inflammation and the stage of the disease, which is the degree of fibrosis. Whenever there is chronic inflammation in the liver, you start off with a little bit of fibrosis, and then you can have more extensive bridging fibrosis, and the end stage would be cirrhosis, which is diffuse extensive fibrosis of the liver with regenerative nodularity. And when you get to the stage of cirrhosis, it's irreversible. But in addition, sometimes we would identify other concurrent disease processes as well. For example, in someone with Hep C, they quite often will have a little bit of fatty change in the liver. If the patient also happens to be an alcoholic or drink a lot or consume a lot of alcohol, that could exacerbate the fatty change. So we can identify concurrent disease processes in addition to the known chronic hepatitis C. And so a liver biopsy these days in the context of chronic Hep C would usually be done if the patient is not progressing as expected. If there is sudden abnormality, sudden surge of the liver enzymes, or if there is any atypical clinical pictures, then they would do a biopsy.
So it's really changed from when we were all training where everyone with Hep C got a biopsy.
Yes, very much so. And another late consequence, as Mike has previously mentioned, is the presence of cancer. And even if the patient is treated, if there is no significant fibrosis, the patient is still at an increased risk of hepatocellular carcinoma. So those patients are usually closely follow up, annual or second biannual scan. And then if there is any lesion, they would take a biopsy. And sometimes it could be very early cancer or even in the precancerous stage, or again, any other coexisting abnormality. So these days, liver biopsies in the context of hepatitis C are usually done for these reasons.
And Mike, another area of the gut where you do a lot of testing is the stomach, and particularly in the context of a bug called Helicobacter pylori. Isn't that right?
Yes, that's a bug known as part of a great medical story, and I might just start with that because I did some training in Perth where these two doctors, one a pathologist, Robin Warren, and Barry Marshall, the gastroenterologist, they started to see patients where these peptic ulcers were full of this particular spiral-shaped organism, and they noticed that there was a pattern, and they tried to get recognition for this, that these peptic ulcers were not caused by stress, but actually by a bacteria that lived deep in the lining of our stomach. So it took them about 20 years to get the sort of Nobel Prize in Physiology in 2005, but this is a bug that still causes infection in about 30% of our Australian population. It's higher in migrants and the elderly. So any of those groups should consider testing. We can test in a number of different ways, non-invasively and invasively. The non-invasive tests involve breathing into a balloon. It's called a urea breath test, and we can analyse that for evidence of the organism growing in the lining. Another non-invasive method is actually by looking for evidence of the bacterium in the stool. So this is the Helicobacter pylori antigen test, and that's virtually as sensitive as well. Moving towards invasive methods, we frequently get biopsies from gastroenterologists who are trying to diagnose the cause of upper gastrointestinal symptoms, and we can culture the organism with some degree of difficulty, but are successful in most cases. And when we can culture the organism, we can actually look for what it's sensitive to, because it's not a simple just one antibiotic. It's actually two antibiotics and an acid suppression medication. But we know that, for example, resistance to one of those key antibiotics, clarithromycin, is increasing, and in some studies it's 25% in people that haven't really been exposed to treatments for it. In those that have failed treatment, it's more likely to be above 80% in some studies. So we now have a test, a molecular method that can actually look for the resistance mutation in the setting where we can't grow it, for example, or when we detect it in stool. And I think this is really helping patients get on the right treatment rather than putting themselves through treatment that might have side effects and it's not going to work. We get them onto the correct combination therapy sooner rather than later.
And Caroline, presumably you also do a lot of work on gastric biopsies, and it's not all Helicobacter pylori. What is the most unusual thing that you found on a gastric biopsy?
We see all sorts of unusual things. One of the very important role of a histopathologist is to be on the lookout for unusual pathological processes. Just before I get to that, I want to just say, with Michael's comment previously, in the old days, because the Helicobacter organisms that Michael mentioned, we could actually see that under the microscope. In the old days, you get a gastric biopsy, you have information, and you have the Helicobacter, that's the diagnosis. But these days, just diagnosing the Helicobacter may not be the end of the story, especially in patients who have persistent infection despite previous treatment or recurrent disease. So this is, again, a situation where we can enlist the help of our pathologist colleagues, microbiologists in this case. If we do see Helicobacter, we can send the specimen, the actual slide specimen, to microbiology, and then they can test for resistance and things like that. Now, in terms of interesting thing, unexpected thing in the gastrointestinal tract, there are many, but one case which I came across a few years ago, we had a patient who presented with gastrointestinal tract bleeding. And when the gastroenterologist went in and did a upper and lower endoscopy, there were multiple little red dots within the stomach and in the duodenum. So the gastroenterologist took a biopsy and we got the specimen. Now, when we look at it under the microscope, it's a very, very unusual appearance. It's actually a form of cancer called angiosarcoma, which is tumor deriving from blood vessels. And so in the gastric biopsy and in the duodenal biopsy, there are little foci of these angiosarcoma areas. And so angiosarcoma, it's a soft tissue tumor, pretty rare. very, very rare in the GI tract, but can occur. But the fact that there are multiple tiny little foci instead of one big lesion make us suspect that maybe it's coming from elsewhere. So we fed the information back to the gastroenterologist. The patient had further investigations, and at the end, it turns out that the patient actually had a primary angiosarcoma in the lung, which was not discovered at the time of the presentation. So this is an unusual case of a primary very rare soft tissue tumor in the lung presenting as GI bleeding. So we always have to be on the lookout for unusual presentation. Yeah.
And on that track then, moving down the gut, a lot of work you would do would be looking for and confirming inflammatory bowel diseases. Can you tell us a little bit about what you look for with those investigations?
Sure. Inflammatory bowel disease, we usually refer to as idiopathic inflammatory bowel disease because there are many conditions that cause inflammation of the bowel. But specifically, idiopathic inflammatory bowel disease, there are two main types, ulcerative colitis and Crohn's disease. And ulcerative colitis affects the colon and the rectum, whereas Crohn's disease can affect anywhere from the mouth to the anus, so the whole of the GI tract. And patient usually presents with bloody diarrhea, abdominal pain. They can have malabsorption, malnutrition, depending on the areas that are involved. And in severe cases, the patient can actually present as a medical emergency with toxic megacolon, is when the colon is so severely inflamed that it just basically stops working and then it becomes very dilated. And if untreated, that can lead to perforation. And also other things like in Crohn's disease, you can get stricture formation, areas of narrowing of the bowel wall, and the patient can present with obstruction, bowel obstruction. And in patients who have long-standing idiopathic inflammatory bowel disease, there is increased risk of cancer. So usually after about 8 to 10 years, these patients are followed up on a regular basis by a gastroenterologist. They would do an endoscopy and they would take multiple biopsies of the affected area. And what we look for, hopefully we don't actually see a cancer, that would be a bit late, but occasionally we do. But what we're looking for firstly is the degree of inflammation. The more inflamed it is, the more chronic it is, the higher the risk. And also, secondly, we can actually see dysplastic foci, which are pre-malignant areas. And if you leave them untreated, they do have quite a high risk of progressing to cancer. So these are the things that we do on a regular basis in patients with chronic idiopathic inflammatory bowel disease.
And Mike, along the vein of IBD, inflammatory bowel disease, you're also very interested in and do work on some of those novel therapies for these conditions, including things like fecal transplant, which might sound very odd to some of our listeners. Can you tell us a bit about that?
Yes, it is an odd sort of approach, but in fact, thousands of years ago, the Chinese were recommending this yellow soup to people with gut disorders and seeing improvements. So it's been around and probably has a greater following in places in Europe, for example. But here in Australia too, we've done quite a lot of fecal transplants. And now we're at the stage where Lifeblood, the Red Cross, actually has donor stool that can be provided for patients with severe gastrointestinal problems. Particularly the one that I'm thinking about is called Clostridium difficile colitis. And if you've had a couple of recurrences already of that, which is not uncommon, then that is a recommended approach that is very efficacious. It has some use and some evidence in the ulcerative colitis group as well, where you can improve or get people into remission, but that's, I think, still in the early phases of study. What's very exciting that I read about recently is our colleagues in Microbiology, they had a paper accepted by Nature, and it was actually on just a single live biotherapeutic bacteria that they discovered with their metagenomic approach, finding that this bug was in the healthy guts, but not in the IBD patients. And so this bug that they've named Hominoenteromicrobium mulieris, and this is a particular bug that they've shown in the mice colitis model to actually heal their colitis. And so just based on the metabolic byproducts, this is actually healing. And so this sort of fits with a lot of the work that we're now starting to see in coming out from other nature journals, showing that there are healthy gut bugs that can actually be fostered with certain diets, and that those people with diseases like cardiometabolic problems or obesity or inflammatory bowel disease, they have a signature that's different and more heavily populated by unhealthy bugs. So we might get into that when we talk about things that we can do to nourish our gut microbiome a bit later.
And Caroline, you help clinicians a lot with these immunotherapy type patients for things like inflammatory bowel disease in your MDT meetings, don't you?
Yes, we do. For those who are not familiar with MDT, it's multidisciplinary team meeting. And it's when we actually have meetings with all the relevant subspecialty doctors. So in the GIT, we would have the gastroenterologist, the pathologist, sometimes the radiologist, and microbiologist, where we discuss individual cases of the patients. And very complicated cases are usually discussed in these meetings so that everybody can contribute their opinion and then come up with the best treatment option for the patient. Now, one thing I want to mention is with the advances in treatments, we are seeing different types of pathology these days. In the old days, for example, inflammatory bowel disease, okay, you see if there is much inflammation, if there is any complication, or if there is any dysplasia or cancer. But these days, we are seeing emerging pathogens, for example, cytomegalovirus, with the use of very strong immunosuppressive agents, such as some of the biologics, to treat these conditions. The patient is very immunosuppressed, and therefore they are very prone to what we call opportunistic infections, which previously would be quite rare. So these days, in patients with inflammatory bowel disease, if we see severe inflammation or ulceration in the biopsy, we routinely would do a CMV stain. And sometimes the CMV could be the cause of the flare-up, or more commonly, it's a combination of CMV and the underlying colitis that cause the flare-up of the patient. And recognizing the CMV is very important because if there is CMV, you have to treat the CMV as well as the underlying colitis. And again, we enlist the help of the microbiologist quite often in these sort of scenarios.
Yes, recently I had such a patient that as an ID physician, they'd had these novel immunotherapy checkpoint inhibitor for example, metastatic melanoma, and they developed exactly that, very severe colitis and hepatitis, grade 3, and their colitis seemed to keep persisting despite treatment with immunosuppressants like the high doses of steroids and other biologic therapies. And we did manage to detect CMV in the blood of this patient and also herpes simplex virus. So because his immune system was so under attack, these viruses that he was controlling prior to this immunosuppression were starting to manifest. And so he managed to get better with antiviral therapy rather than escalating his immunosuppressant therapy, which without detection of those microorganisms, we might go down the wrong path. So.
And with some of the newer treatments that Michael mentioned, some of the newer anti-cancer treatment, the immune checkpoint inhibitors, we are also seeing a different pattern of pathology in the small bowel and the colon. It's more common in the colon. You can actually get changes that are very similar to idiopathic inflammatory bowel disease. And in the small bowel, you can get changes that are almost identical to celiac disease. And again, this brings back to my earlier comment that it has to be a clinical pathological correlation. If we didn't know that the patient was on such treatment, we would probably miss the diagnosis. So it's very important that we actually get a full clinical picture to help us arrive at the correct diagnosis.
Caroline, you had a very interesting case many years ago, I think, with one of the earlier immunosuppressant therapies that I'd love to hear that story.
Sure.
Again.
Yeah, so many years ago, we had a patient who's kidney transplant patient on immunosuppressant, and he started losing weight. He had malabsorption, diarrhea. He lost, I think, within a period of 6 months, 18 kilos. And so the clinician just had no idea. They check all the stool culture and everything. He didn't have an infection, and he just kept losing weight. And the gastroenterologist looking after him actually did endoscopy twice and took small bowel biopsy, and exactly he had changes that are quite similar to celiac disease, but all his other tests for celiac disease were negative. Anyway, so at the end, out of desperation, because he was losing so much weight and he was almost succumbing to the disease, they decided to ask the surgeon to go in and take a full thickness biopsy. And I received the biopsy. And again, it showed very severe changes that are almost identical to celiac disease. So I was scratching my head, and so I looked up some journals and did a very thorough literature search. And at the time, I think there was one case report of similar changes seen in patient who was on mycophenolate. Mycophenolate is a immunosuppressive agent that is used to treat certain autoimmune disorder as well as for kidney transplant patient. So I thought, we'll see on mycophenolate. So I rang up the clinician, and lo and behold, he was actually on mycophenolate. And I said, since we've excluded almost everything else, let's just see stopping the mycophenolate and switch him to another type of immunosuppressive agent. And he just got better immediately. And then he gained his weight back. And then after a few months, the clinician actually repeated the endoscopy, and the biopsy looked a lot better. And because nowadays it's actually common knowledge among histopathologists that mycophenolate can do that. But this case was about 15 years ago. It wasn't so commonly known. So we actually published a case in one of the prestigious medical journal, Lancet. Yeah, so it's always on the lookout for potential causes, unsuspected causes, and also, again, back to good clinical pathological correlation.
So you had the second case report of that condition?
At the time, yes, yeah.
And Mike, one of your great interests outside of gut pathology is gut wellness in terms of dietary impacts on health. And that also ties into the new metagenomic testing when it comes to efficacies of immunotherapies, I believe. Can you tell us a bit more about that?
Yeah, I might just start with some of these amazing cases that we're starting to diagnose with this metagenomic test called the MetaPanel. This has allowed us to pick up the cause of gastrointestinal symptoms, for example, in a patient who'd had 5 years following a travel in Africa, and we diagnosed a particular type of helminth or worm called schistosomiasis. And just after a couple of treatments for that, his symptoms resolved completely. So that was a great success. Similarly, we've just been hearing about IBD patients, and they're at increased risk of carrying these gut pathogens. So we've diagnosed some of these E. coli pathotypes causing their symptoms, a weird microsporidian type parasite as well in someone that we were able to clear. And so there's great potential in this sort of test for those that haven't got a diagnosis after many months, because many of these patients that we've seen have really lived with symptoms like diarrhea and abdominal pain for many months, if not years. So I think we're at this point in time where we're very lucky to have these technologies where the computing power allows us to understand all the DNA that's sequenced. And so we're starting to understand the gut microbiome a lot better with these technologies. And so this meta panel also gives you an idea in about 3/4 of patients that present for this test with chronic unrelenting symptoms. They have evidence of low gut microbial diversity and richness. And that sort of is something that we can start to at least reassure them that there's no pathogen, but maybe suggest that potentially using a dietary approach, we can actually improve their potential dysbiosis. So that leads me to maybe some messages that the patients and listeners can potentially gain from these dietary changes. I really like this aphorism of Hippocrates, who lived 2,500 years ago and said, "Let food be thy medicine and medicine be thy food." And I think that's still very relevant today, and we're starting to, with this technology, understand that the microbiome is at the basis of a lot of our disease conditions, our chronic diseases like cardiometabolic disease and inflammatory bowel and even cancer. So the key messages that we're starting to realise that are important to nourish a healthy microbiome are, I think about them in just two main approaches, and that's to eat more plants and to avoid or limit those foods that are going to be a bit toxic to our gastrointestinal symptoms. So eat more plants, a landmark study in the American Gut Project, in fact, in 2018, showed that those patients or those people, they were just American citizens, but I think there were some from around the world as well, that those that were eating more than 30 different plants a week had the best microbial diversity. And studies have shown that usually correlates with better health and less carriage of these unhealthy conditions. In fact, those people who were eating those that high plant-based diet also had lower antimicrobial resistance gene carriage too, which we think probably comes from the food, particularly the meat products that they're eating, because its antibiotic use is overused in livestock industry, especially overseas. So the plants that we can focus on, for those that are worried about how can I eat 30 plants, I would recommend just taking it slowly and just building up. I remember it by the 6 or 7 key groups. And so most listeners probably think of just fruit and veg, and that's easy to remember. But there's also legumes, so plant protein that really comes from legumes, such as lentils and chickpeas and soybeans in particular. And then another group is your nuts and seeds. And then herbs and spices are a 5th group. And we also, I should have mentioned earlier, the whole grains. So grains are a real key superfood for our healthy gut microbes in our gut. That I think is about 6, and 7 is your pantry essentials. So a lot of listeners enjoy coffee. I prefer matcha, green tea, and dark chocolate. These are also plant products, would you believe? So, getting back to the vegetables, I think it's important to just illustrate that there are some vegetables that are better than others. And so this idea of eating the rainbow is really important, because those foods with bright colours, reds, purples, yellows, they have more polyphenols. These are sort of the modern term for antioxidants, and these have cancer-fighting properties and help regulate our immune system through the gut. We know that there's a gut-brain axis, for example, that helps. If we eat healthy foods, we're going to have better mood, less fatigue, etc. So I think these richly coloured vegetables, or cruciferous vegetables like broccolis and cauliflower, tomatoes are a great source of vitamins and minerals. Then another key group in vegetables is your alliums. So these are things like garlics and onions, asparagus, and artichokes. I think about them as the 3 A's. And so that's a key group to consider, because these provide prebiotic fibre for, again, to nourish our healthy gut microbes that then produce all these good healthy chemicals that nourish the colonic epithelium. A third group in the vegetables I like to always recommend are the fermented vegetables. So these are not just prebiotics, which are the vegetables, but they come with their own microbiome. And so I think Eli Mechnikov more than 100 years ago was studying why these Bulgarians were living so long. They were eating fermented products, particularly fermented dairy in the form of these yogurts, and he was sort of now considered the father of probiotics. But I think cultures have been eating these fermented foods for many, many millennia, and you can remember them as the sort of a simple way is all the Ks. There's about 5 of them that I can think of, like kimchi, sauerkraut, if you like the German spelling. There's kombucha, a nice fermented drink. Kvass is another drink that looks like Coke, in my opinion, tastes better. So these foods are very healthy for our gut microbes, and I think you've got a favourite fermented food. I remember you telling me about, Caroline.
That's right, sourdough bread.
Okay.
Yeah, made from wild yeast. Yes, you have good memory. I'm actually a very keen sourdough baker.
Yes.
I've been doing it pretty religiously, almost weekly for the last 10 years.
Mm-hmm.
Yeah,
That's really good. Some other fermented foods that you've just made me think about are tempeh is an Indonesian one, and I think natto.
natto, that's
you
right.
like
I also do natto as
I
well.
can't get a taste for that, but
Exactly. It's definitely an
Acquired
acquired taste, but I started doing it mainly for health benefit initially. Yeah.
Yeah.
So, Caroline, is there any sort of particular takeaway message that you'd really like for our listeners to take home today?
Sure. This is a message that I've sort of reiterated a few times already, but especially for our referrers, for the clinical colleagues, it's extremely important when you send us a specimen to provide us with the relevant and correct clinical information, because that would help us in achieving the correct diagnosis more smoothly. And the other thing is we do actually like to talk with our clinical colleagues, discussing, especially in difficult cases. We love to talk with you and discussing all the possibilities. And so if you get a phone call from us, it's because we would like to discuss an interesting case with you. And also, on the other hand, if you have any particular concern about any cases or any particular issues, problems that you have in mind, it's very helpful to give us a call beforehand and let us know, so we will watch out for the particular issues. Basically, we all want to work together for the good of the patient. And the more clinical information we get, the more likely we'll arrive at the correct diagnosis, and then we can give the recommendation regarding treatment, prognosis, and all that. And ultimately, that would benefit the patient.
I'd like to echo that recommendation as well, especially with regard to this new meta-panel test where we're only reporting what we consider pathogens. If there's a doctor that is particularly interested in a certain organism, if we don't know about that, we can't look into the background of the test and potentially have a discussion, at least over the phone, about that particular possible pathogen that we still don't consider there's enough evidence to support it, for example. So I think it's really helpful to have that clinical history, and we can then support people. I think just with regard to that metagenomic test, that for listeners to just realise it's available throughout Australia from all our sonic entities, and we hope that in the future, as the testing technology progresses, we'll have a much more encompassing test that will be able to not only diagnose pathogens, but also give you a very clear understanding about the health of your microbiome. And I think that's already starting to emerge in some tests, like our partner Microba's Meta Explore test, for example, is a very good example of that. And I know a lot of people are taking some support from that test.
And for our listeners at home, if you go to the launch page for this podcast, there'll be a whole swathe of resources, many of which have been mentioned today, including many of the articles that Mike and Caroline have mentioned. So thank you both so much for joining us today. Thank you so much for your time and for all the work that you do for doctors and patients, and for sharing that with us.
Thank you, Ben.
Thank you,
It's been a great
Ben.
pleasure.
Yeah, it's a pleasure.
And for our listeners at home, doctors or patients, if you scroll below, you will find many of the resources that have been mentioned today, a whole swathe of articles that Caroline and Mike have brought up, and lots of resources for your further education.